maybe a tough act to follow. So thank you for your time today. I'm going to switch gears a little bit and share with you sort of my mission and my passion in life. And I think it fits really well with the Meliora mission of Ever Better, and I hope you'll see that today. So I joined here after spending 12 years at St. Jude Children's Research Hospital, where our tagline is finding cures and saving children. And I would say my personal tagline is finding just right. And that's what I'll share with you today. And this is truly the goal of pediatric and AYA, or adolescent and young adult cancer treatment today. So I'm going to highlight a case of Hodgkin lymphoma, which is my primary work, to illustrate my points today. That first, of course, we must cure. And these are the survival curves for patients with Hodgkin lymphoma. And what you can see in the blue arrow is that actually we've been curing patients for decades, which is wonderful. And so for Hodgkin lymphoma, we are in a beautiful space where we do have cures. So we need to learn how to do it best. But of course, to cure is not enough. We all know these stories, and this is one of mine. Dr. Brian Sorrentino was a gifted researcher and amazing human at St. Jude. His work discovered gene therapy that solved severe combined immunodeficiency, or SCID. He died at the age of 60 due to radiation-induced lung cancer from radiation he received as a teenager for his Hodgkin lymphoma. His work was published in the New England Journal of Medicine shortly after his death. So what we know, first, we must cure, but to cure is not enough, certainly for pediatric and AYA patients. So we must aim for this premise of just right. So a second look at these same survival curves shows you that, sure, the 5-year survival, which is often what we show in publications and commend ourselves for, 5-year curves are not enough. These are pediatric and young adult patients. 5 years later, the 15-year-old is now 20. 5 years later, a 30-year-old is 35. What happens to them after matters just as much. So when you look at these survival curves with a different lens, what you see is these curves continue to fall. And the reason this is important when thinking about Hodgkin lymphoma is that if Hodgkin lymphoma comes back, it usually comes back within the first 5 years, which means these curves that are falling after 5 years, patients are not dying from their lymphoma, they're dying from late effects of the cures and treatment that they received. And of course, it's not just about our patients living or dying. It's, are they surviving and thriving? So this is other work that I've done showing it's not just mortality and outcomes, it's what's the cumulative incidence of chronic health conditions. How are they living? And to illustrate this point, you can see just in the top right curve, for example, red lines are survivors, blue lines are immaculately age-matched controls. And what this shows us, in our patients who are 25 years old who survived their Hodgkin lymphoma, they have the same cumulative incidence of chronic health conditions of people 20 years older. We have to do better. This is a curable disease, and we have the data to show it. So we must find a just right. So when trying to find better cures, it's important to think about what is the biology of a disease. And Hodgkin lymphoma is a rare cancer of the lymph nodes. And what do we know? Well, our lymph nodes grow in response to an antigen. Somehow a mistake is made. B cells lose their CD20 that they should have. They gain CD30 that they shouldn't, and they become these binucleate Reed-Sternberg cells. So it's important in that biology to think what's different about cancer cells than healthy cells in the body, and can we target that, right? This is the era of medicine we're in today. So in Hodgkin lymphoma, they express CD30, and that's expressed on very few healthy cells in the body. And I'll come back to this in a minute. So it makes a great target. And of course, when thinking about the disease, the H is capitalized. Thomas Hodgkin was indeed a human. And I will just summarize this slide to say there are many different variants of Hodgkin lymphoma in that grouping. 4 today are all considered classic. They express the CD30, and that excludes a now rare variant called nodular lymphocyte predominant Hodgkin lymphoma that's only about 5 to 10% of all cases, but still warrants our attention. And when thinking about the disease, it's important to think about who is it happening in. So Hodgkin lymphoma is the most common cancer in adolescents and young adults. What can we learn from that? Many things about the immune system. And when thinking about the finding just right, the point I'm trying to make is the most common population are young. So for the disease, the late effects do matter. So how do we find this just right? This has been my passion and life's work. So at St. Jude, I run our Pediatric Hodgkin Consortium, and we ran a series of trials. And the whole point is use the data and let the data drive and inform our changes for the future. So the curves on the left, you don't have to know much about the outcomes to know that there's a curve that's clearly lower. So when we looked at the treatment regimen we used, we found a subpopulation that didn't do as well with that backbone and said, time to make a change. So we looked across to our European colleagues, adapted a different backbone, and took that same set of patients from the lower curve, augmented therapy that was a good match for them, and were able to elevate their outcomes to be just like everybody else. So this is how clinical trials change the future for everyone. Next is to improve upon the standard of care. We can try to replace toxic agents with less toxic ones. And these are two good examples in the field, exemplified here in the context of Hodgkin lymphoma. So on the left, antibody drug conjugates. Savvy way of saying, instead of just giving a drug that we know works to the body and having it affect healthy and cancer cells at the same rate, let's target it. So using CD30, going back to that thing expressed on Hodgkin-Reed-Sternberg cells, let's take an old drug, it's called vincristine, a microtubule inhibitor, and make it fancy and target it to CD30 through antibody drug conjugates. So that's one way. The second way is to use our immune system smarter. I love this teaching slide with our students because this is so cool to me. It's getting our own body to actually cure and eradicate their own cancer, right? So this is what are all the ads everybody sees. What's an immune therapy, a checkpoint inhibitor? Nutshell. Our T cells see cancer cells and are supposed to kill them. But cancer cells are smart and they touch at other sites. And there's a site that binds called PD-1, PD-L1. And when the T cells see the cancer cell and send their kill signal, the cancer cell, through the binding, turns it off. So people have made drugs to block that binding site called checkpoint inhibitors. And so we have tried to utilize them so that the T cells see the cancer cells send the kill signal, and due to the drug, the cancer cell cannot turn it off. That's the premise of immunotherapy today. So this is what we've done. And Dr. Friedberg, who's the director of the Wilmot Cancer Center here, was champion of this entire trial that was a huge success. So he took two backbones, two common treatments, and used the antibody drug conjugate with one arm and used the checkpoint inhibitor with the other and ran them head to head to say which is better. The outcomes were astounding and very clear, and the early readouts actually closed the trial early because the checkpoint inhibitor was wildly successful. And the short answer is there are many different age groups, so it's super important that we have every trial publish their age-related subsets to make sure that the data is applicable to the patient in front of you. And so in our pediatric cohort, the same results were shown. Next, it's not just about curing patients. It's not just about the late effects of treatment. It's about applying all that we have learned to the patients of today. There's so many other things in the context of treatment. It's not just about the drugs. So on the current trial I wrote, I made 6 other advances to try to not just cure patients, but to reduce all toxicities of therapy, including financial, the amount of times they come back. And so for the sake of brevity, I'm just going to show one. For Hodgkin lymphoma in the past, people came back after their therapy was done, and every few months they received a CT scan. If anybody has ever received a scan of your own, there is so much anxiety that goes with that, let alone the cost and the follow-up and the time off work and all the things that go with it. And so the question is, do things like this matter? Do they make a difference? Is it worth it? And so these studies that we did showed it didn't matter. Patients had 5 CT scans that were routinely done after the end of therapy. And whether your disease was caught on the scan early or we waited until they had symptoms, the outcomes did not change one bit. The only thing that mattered was the time from the end of therapy to relapse. And so this is just one small way that on the current trial I'm running, the end of therapy imaging is none. We are all done. We need to use the data. If it's not working, we are able to go backwards in medicine. Now we just use a really good history and physical exam, and it's better than the surveillance imaging, and we are saving thousands of patients, not just anxiety and cost, but also all the time associated with it for no survival benefit. And next is the premise of never stop asking why. You know, we have a lot of old drugs that we learn. This is how you give it. It's this many days a week. The question's why? Because often we don't know. We fractionated some drugs, we didn't for others. So on the current trial, I asked a why. There's a very old drug called bendamustine. We have over 50 years of data. It was historically given one half of it on day 1, the other half on day 2. Some drugs need to be fractionated, where you come back each day for a little bit of a dose because they hit certain cell cycles. So you give a little dose, wait for cells to go through a cycle, give another dose. That's not how bendamustine works. Bendamustine's efficacy is related to the area under the curve. So if you fractionate it or give it in one day, it will work the same. And the toxicity is the height of the peak. So we are savvy and said, let's go back to the old data, which said you could give safely both days in one. And I studied this with a fellow on our trial, and we were able to show exactly what we thought. It was super well tolerated, no increase in toxicity, and the exact same efficacy, which means now not just in this trial concept, but for all patients who receive this drug, you can just give it over one day with no added toxicity and the same efficacy and save thousands of patients the second day visit. So again, never stop asking why. I only have a moment, and I will just briefly summarize this last concept, which is standardization avoids overtreatment for rare diseases, and it's hard to study them, but it's absolutely needed. Nodular lymphocyte predominant Hodgkin lymphoma is rare. To answer meaningful scientific questions, you have to bring the whole world together. So that's what we did. So I started a global initiative to optimize treatment for NLPHL for all patients around the globe. I did this together with a radiation oncologist from Stanford, and all the credit goes to Monica Palese, my project manager, who's been essential. Today, we have over 150 researchers from 29 countries on 6 continents, and I've done this. We asked one survey question that said, to prove the entire point, for very easy to cure NLPHL, what regimen do you use? And the point of this is people chose everything from a laundry list. This is a curable disease that does not need aggressive treatment. And so by providing data and a standard, we can simply spare patients late effects that they never needed in the first place. So that's what we've done. We put together over 2,200 cases. We just published an international prognostic score and are using this to open a frontline trial. And with that, I'll say thank you. I'm so grateful that people pay me to do this job I love. This is our lymphoma team, and I'm super happy to be here. Thanks for coming today.